Good morning, everyone. Thank you for being here. My name is Jackie Gahagan. I'm from Dalhousie University. It is my honor and great pleasure on behalf of my social science co-chairs, Zach Marshall and Francisco Ibanez Carrasco, to introduce our CAHR 2014 social science plenary speaker, Dr. Richard Parker. But before I tell you a little bit about Dr. Parker and his talk, I would like to acknowledge the Social Science Scholarship Award recipients, including the Vaccine Scholarship recipient. Congratulations to each of you. Well done. We would also like to encourage you to check out our social science oral presentation sessions, which include papers related to topics such as beyond at-risk and hidden populations, prevention and intervention grounded in local realities, social, structural, and systemic drivers and contexts of HIV risk, and intersectional framing of HIV, sex, and gender, contested context, experiences, and responses. You can tell by the titles that we had a great time working together. So again, thank you to my co-chairs for your imagination. Thank you to the Scientific Program Committee in general for being supportive of our work. At the end of this session, we invite you to go to the exhibit and poster hall for a break. And yes, there will be coffee, there will be snacks, so please join us there. In terms of our social science plenary speaker, I had the pleasure of meeting Dr. Richard Parker, dare I say, in 1997 at the International Summer Learning Institute for Social Sciences and Humanities and HIV and AIDS Research. Thanks to Ted Myers, Liviana Calcevera, Eleanor Matika-Tyndale, and others who put that together. I have to say, as a grad student, it was somewhat intimidating to be surrounded by what we affectionately referred to as the senior HIV/AIDS scholars. I've since come to realize that with our diverse theoretical and methodological perspectives that underpin our approaches, we're all in this as a collective effort. As such, I would encourage you to engage with Dr. Parker and the other social scientists who are here in lovely Newfoundland, and to use this opportunity to learn together from each other. The annual CAHR conference provides, unlike many other opportunities, a chance to really share and interact in person with each other. So let's make a point of talking to those that you may have read their material, but you've never actually met in person. So challenge yourself to go meet a social scientist today that you did not know previously. That's the way we do it as social scientists. We might not agree with everything that we hear and see in the sessions, but I think this is a really important means of learning from each other. So please do engage with your fellow social scientists. And, you know, for example, I'd like to highlight the fact that Dr. Richard Parker, although we claim him as our own, as a social scientist, as we should, I think he actually provides a really important example of how social scientists can bridge between the social sciences and public health more broadly. So I am, by way of introduction, just going to give a couple of comments, if I may, Richard, and then over to you. So by way of introduction to our CAHR 2014 social science plenary speaker, I would like to note that Dr. Richard Parker is a member of the Committee on Global Thought at Columbia University, where he directs the Center for the Study of Culture, Politics, and Public Health. Richard is also the director and president of the Brazilian Interdisciplinary AIDS Association, as well as founder and co-chair of Sexuality Policy Watch, and editor-in-chief in Global Public Health. The title of Richard's talk, for those of you who haven't seen it already, which should be a fascinating, engaging talk, is Why Social Science Matters More Now Than Ever in HIV Research. And just to give you a sense, this will be an intriguing review of the history of social science approaches and paradigms for HIV research and interventions, an analysis of the social science dimensions of contemporary approaches to biomedical and combination prevention, a delineation of the reasons why social science research perspectives continue to be an essential part of the broader response to HIV, and lastly, an examination of the linkages between social science research and policy advocacy in the fourth decade of the epidemic. So again, on behalf of my co-chairs, Francisco and Zach, I'm very pleased to welcome Dr. Richard Parker.
So before anything else, thanks to Jackie for that very kind introduction, and to Jackie and Francisco and Zach and all of the program committee members and organizers for the invitation to be here today. Just a quick personal note as I was thinking about this presentation and looking back over the many years I've worked on HIV, how important HIV work in Canada has been to me. The first International AIDS Conference that I ever attended was in 1989 in Montreal, where I was living in Brazil at the time, and so it was really my first encounter with some of the things that AIDS activists were doing in the late 1980s that were really important in terms of changing my way of thinking about the epidemic. Then I was a plenary speaker at the Vancouver AIDS Conference in 1996. In 1997, the wonderful workshop that Jackie mentioned, organized in Picton. In 2001, I had the opportunity to give the inaugural keynote. I think it was before it was called the Mark Weinberg Lecture, but at the CAHR conference in Toronto in 2001, to participate in the organizing of the Toronto International AIDS Conference in 2006. For a decade, from 2000 to 2010, I served on the board of ICAZO, its secretariat located in Toronto, and now the invitation to speak here today. Canada has been important to what I've learned about this epidemic, perhaps more than any place else, and I truly appreciate it. So there's the conflict of interest slide, and I think there are none, so I'm going to move past it and get into the focus of the talk today. Like Richard Elliott in his Mark Weinberg lecture last night, in this talk I want to emphasize the importance of history and of learning the lessons from history about the ways in which we've thought about HIV and AIDS, as well as the ways in which we've responded to it. I'll try to do that by looking at sort of three different things, not sequentially. They'll kind of be mixed together over the course of this talk. But the first is the recent focus on biomedical and combination prevention, and to try to understand where that is situated historically in the ways in which we've responded to the epidemic. I'll get at that by looking at what we might call the shifting research paradigms, and also the social, cultural, political, and economic forces that at some level are articulated in the shifting paradigms. And I will make the case that social science matters now more than ever. I think it's been important from the very start of the epidemic, but I'd like to try to emphasize that even in a time of biomedical prevention, social science is absolutely crucial to the most fundamental questions that we're asking about the epidemic and that we need to try to confront. In thinking about the long sweep of 35 years of responding to HIV, particularly in the area of HIV prevention and social and behavioral research, I think that there are at least 5 distinct perspectives that at some level have also been historical moments that it's worth distinguishing and saying something about. The first and earliest is what I'm going to call community-based prevention approaches and responses. I sometimes describe this as community/cultural, but it's the real focus on communities as they respond to the epidemic, and as the first instance of which a response to the epidemic in the 1980s actually took shape. Then the second that I want to talk about is what I'll call behavioral theories and behavioral interventions. The third is structural factors and structural interventions, and then most recently, in the mid-2000s on up to the present, I think, biomedical prevention and increasingly combination prevention. These various paradigms don't completely map on to the phases of the response in Canada that Richard Elliott spoke about in his talk last evening. But at some level, I think that they do, and you'll see there are some connections with kind of the 5 different phases of the Canadian response that he identified. So the first, community or cultural approaches. Community or cultural approaches, I think, were most powerful during the first decade of the epidemic across highly diverse populations, countries, communities, and in very diverse settings and in culturally appropriate ways. I think of some of the examples of community responses that were so important in that first decade, and I also realize that probably many people in this room weren't even born during the first decade. So it's especially important to go back and look at some of these early responses precisely because people who weren't necessarily working with HIV when this was the focus of what was going on need to learn about this because it still provides a hugely important foundation for everything that I think we do. Some of the examples that I find most important from that period were what I think we can rightly call the invention of safe sex. It had to be invented, it didn't exist, it needed to be constructed, and it was invented in multiple places around the world in profoundly important ways during this first decade. It was also invented in relation to what I call and think it's important to emphasize the art of caring. That is to say, many of us who began working on HIV very early on in the epidemic, and I began at the very start, our first encounter with the response to HIV and the work that we did was caring for people who were ill. And that experience in communities like the gay community, which at the time was considered to be sort of hedonistic, self-centered, not solidary, not able to take care of and nurture, we proved that to be wrong. And the art of caring and the construction of safer sex in relation to that art of caring, I think, is a point of departure for almost everything that's happened in this epidemic for 35 years. And is really important. I think that was also part of what I'd call the construction of solidarity. Solidarity has been an underlying principle of the response to HIV and AIDS since the beginning of the epidemic on the part of scientists as well as activists. And that importance of solidarity, of understanding the pain and suffering of others, and taking responsibility for addressing it, it seems to me is especially important, as is the cultural activism that emerged in the first decade of the epidemic. Again, it emerged everywhere. Maybe we think of it most paradigmatically in relation to ACT UP or other highly visible activist organizations, but cultural activism, cultural mobilization in a time when biomedicine and public health offered us next to nothing in terms of how we could respond to the epidemic, were profoundly important and have continued to be an underlying principle of organization of the response to HIV since that time, I think. Also, it's important to emphasize something that I learned at the Montreal AIDS Conference in 1989 from a brilliant presentation by George Rutherford, who at the time was the director of the San Francisco Department of Public Health AIDS office, and who had the incredible courage as a public official responsible for responding to the epidemic using public funds and public interventions, and who got up and said, look, 90% of behavioral change in response to HIV in San Francisco happened before a single dollar of public health funds had been spent on HIV prevention. It happened because the community mobilized. It happened because community experts knew more about what to do than we scientific experts. And that, I think, is a lesson in humility that's particularly important to remember many decades later. I think that this cultural community approach basically was the overarching approach during the 1980s as governments and public health services and systems tried to figure out what to do, often in the most irresponsible ways. These kinds of community-based responses were the best thing that we had. By the end of that first decade, in the late 1980s, early 1990s, research establishments around the world had begun to try to mobilize themselves and try to develop investigations and theories and methods that could be used to help the communities that were being affected by the epidemic, and a kind of new wave of approaches, which I describe as behavioral theories and behavioral interventions, began to be rolled out around the world, especially in the United States. The United States has typically put great stock in behavioral research, and much of the early behavioral research in response to HIV and AIDS coming out of places like the NIH and the various research centers around the country in the U.S. Emphasized a cognitive behavioral approach, and at some level exported that as the dominant research paradigm in social and behavioral sciences during that period of time in most places around the world. There were important alternatives that also emerged with a greater emphasis on the social than on the behavioral. I think much work carried out in Canada, in Australia, and the UK certainly sought to balance the focus on behavior with a stronger focus on social and under-social, cultural, political, economic kinds of considerations. And that was an important tension at that period in time. Nonetheless, behavioral theories and behavioral interventions tended to dominate, and I think there are two key kinds of orientations that were important in terms of those behavioral approaches. One was an attempt that I don't think was very successful to try to apply models that had been developed in relation to other issues like smoking cessation or other health behaviors, to try to apply those models to HIV and see if the sorts of interventions that had been developed using those models in relation to other quite different behaviors could be used as a way of responding to AIDS. A second approach, which I think was probably slightly more successful, although also had its limitations, was to develop new cognitive and behavioral approaches specifically for HIV. So if the health behavior model and applying it to HIV might be one example of the use of other behavioral models to think about behavioral change in response to HIV and AIDS, something like the AIDS risk reduction model developed by the Center for AIDS Prevention Studies at the University of California in San Francisco would be an example of attempting to use cognitive behavioral thinking to develop new models that might be applied in response to HIV. However, I think that even though behavioral models and interventions have continued to be important parts of the field on up to the present, I think that by the early 1990s and certainly by the mid-1990s, we had also become aware of the limitations of those kinds of approaches, of the difficulties that they confronted when they came in contact with the reality of structures and cultures around the world. There are all sorts of barriers that are structural and many barriers also that are cultural that make the implementation of behavioral approaches highly difficult. And by the early 1990s, I think we had begun to realize just how true that was. With the publication of AIDS in the World, edited by Jonathan Mann and Daniel Tarantola and Tom Netter in 1992, we began to articulate, I think, a sense of these limitations in the concept of social vulnerability and in looking at the structural factors and in particular what Paul Farmer and I and others have spoken about as structural violence, the ways in which structural inequalities in axes of inequality like poverty and economic exclusion, like race and racism and ethnic discrimination, like gender power inequalities, sexual discrimination and oppression, age-related inequalities, created profound barriers to trying to develop these kinds of relatively simple behavioral interventions precisely because people's behavior is not is not so easily in their control to be able to change and remodel. There are all sorts of other kinds of structural factors which make that profoundly difficult, as the people in this audience are clearly well aware. I think that social science had a key role at that point in time in trying to understand these structural factors, make sense of them, and to try to think about what we might be able to do about them. Obviously, social science was not the only source of inspiration. There were multiple sources of inspiration, including social medicine and what might be described as the progressive or new public health, which was very much in tune with social science perspectives on these issues. Social science work on fundamental causes of health independent of HIV was clearly very important, and we brought that into HIV-related research. Activist allies and civil society organizations, NGOs, grassroots activists grasped immediately, more quickly than we researchers ever did, how important these structural factors were. And in fact, they were probably the people who taught us about that. And even some allies in key agencies that emerged in the 1990s, if Jonathan Mann probably was forced out of the World Health Organization at some level because of his emphasis on issues related to politics and structure. By the middle of the 1990s, with the creation of UNAIDS, you began to have the adoption at the level of those agencies of this kind of structural perspective that we were advocating for. So I think all of these various players and actors and sources of inspiration were important. The idea of structural barriers and structural interventions obviously had multiple sources of inspiration and multiple roots that continue to be extremely important over time. I think it's also worth noting that at this point in time, historically, again, mid-1990s, 1996 maybe being a fundamental turning point at the time of the Vancouver AIDS Conference, the announcement of the relatively positive results in relation to antiretroviral therapies began to open up a new set of questions in relation to all of these structural issues. And I think it's particularly important to note that the structural turn and this focus on structural barriers was especially important in contributing to the political milieu, if you will, in which access to treatment became a huge political issue. The treatment access movement, in turn, helped to provide the key conditions that would ultimately be necessary for the initiation of a phase of scale-up, both in treatment and prevention programs in the early 2000s. And the recognition that treatment access was going to be one of the most fundamental issues that we would have to address in responding to this epidemic, because if we want to argue that every life matters, then we can't accept the inequalities of the fact that people who are lucky enough to be born in rich countries have access to treatment when people who are unlucky enough to be born in poor places don't. And that those structural conditions put themselves on the table for us as the biggest challenge of the late 1990s. And they helped to provide a kind of foundation for the emergence of the treatment access movement, while in the same time helping us to understand how that movement has evolved over time. And clearly the treatment access movement is still today I think the biggest example of a powerful moral and ethical victory in the field of global health on any issue. If you think about the fact that literally from only 1996 to 2000, when the UNGAS was held in New York City, and then the Global Fund was created and Scale Up was initiated, in 5 years, we essentially won the moral battle. By 2000, it wasn't a question anymore, even at the World Bank, that treatment was not cost effective. It was understood that treatment was a human right, and gradually it was understood that treatment is cost effective and actually feeds into primary prevention in profoundly important ways. It was the biggest victory we've had thus far in the epidemic, and given the amount of time that it took, an amazing victory in terms of overturning what were the kind of universal negative reaction on the part of political leaders and international agencies and so on. So I think the structural turn was a huge turning point in terms of the way we responded to the epidemic. But I also think that it's important to say that, as is true across the 35 years of the epidemic, we also relatively rapidly came up against some of the limitations of our own perspective. So that in spite of the advances that we began to make in terms of treatment access in the late 90s and especially in the 2000s, we also had to recognize that there have only been relatively limited changes in most of the important structures that shape the epidemic, whether that's economic exclusion or gender inequalities or what have you. And we began to have to confront something that I think we knew for 20 years but hadn't adequately confronted, which is that policies and politics may both shape risk and vulnerability more than anything else. The kinds of political silences and irresponsibilities in the first decade of the epidemic that have continued in many parts of the world on up to the present may actually be the biggest structural barrier. Our leaders, whether in the United States, where it has been most obvious for the longest period of time, or in places like Uganda, where it's become profoundly obvious in recent times, and perhaps here in Canada as well, as your politics have changed and different governments have come in and adopted different kinds of policies. Large-scale politics, electoral politics, can actually have more to do with creating barriers to responding to this epidemic than almost anything else. And that also became clear as one of the limits to structural kinds of factors. Faced with these limits, it probably isn't surprising that by the middle of the 2000s, in the midst of the scale-up process, we began to also see a return from a focus on transforming structures to a return to a search for biomedical solutions. Not necessarily just the magic biomedical bullet, but a range of biomedical solutions that would perhaps enable the response to AIDS to escape the difficulty of overcoming structural barriers that were so hard for us to change. There were multiple agents, I think, of this return to the biomedical. I've listed here on the slide some of the big ones. Certainly, the interests of the international pharmaceutical industry are not inconsequential here, even if they may coincide in some ways with our interests as HIV researchers or, in many cases, researchers and activists. What the pharmaceutical industry has at stake here can't be ignored in thinking about the return to the biomedical. Biomedical and behavioral research funders have also played a role. Biomedical and behavioral researchers have all played a role, and the public health establishment. In short, we're all implicated in one way or another. We all fall into one or another of these categories, most of us. And so this return to the biomedical has been something that has been constructed with a lot of help from all of us, and not necessarily as something negative. It may sound like I'm indicting it. I'm not. I actually work and do research trying to figure out how biomedical kinds of approaches can be used more effectively. So it's not that I think that the biomedical is not important. But I do think that the biomedical and biomedical prevention generally has been talked about in ways that maybe oversimplify it. It's a large umbrella, and I think it's particularly important for us to remember that everything that gets put under that umbrella is not actually all the same. and that it may be useful to make some more nuanced distinctions between a number of different kinds of things that are labeled biomedical prevention. Particularly, I think we have to distinguish between biomedical products that are new products, that are experimental products, that are under investigation, that are under development, that for the most part haven't yet been rolled out in any kind of public health way. We also have to distinguish between those and what we might call treatment as prevention, i.e. antiretroviral treatments adapted for use in prevention programs. And the third, the older biomedical techniques that have been adapted for the prevention of HIV. So let me just say a few words about each of those. In terms of inventing new technologies, vaccines and microbicides are obviously what I'm talking about here. There, as many of the sessions in this conference certainly make clear, there's been progress, but also yet no total breakthroughs in relation to the development of these new technologies. In my opinion, they need to continue to be a high priority in terms of HIV research, but we also need to be relatively realistic about where we are in terms of developing them. A second set of issues relates to treatment as prevention, particularly post-exposure prophylaxis and pre-exposure prophylaxis. Here what we're talking about obviously is this attempt to use antiretrovirals in ways that will make it possible for people to use them as tools in primary prevention. In my opinion, an extremely high priority that we need to continue to investigate, to do work on, to understand the social dimensions, because it isn't simply taking a pill. Taking a pill is an incredibly complex social production, social construction. We need to understand those social dimensions. We need to try to bring these technologies and techniques into the toolkit of prevention. But we also have to do that recognizing that we live in a world in which less than a third of the people who need access to antiretrovirals to treat their HIV infection have that access. So we can't assume that in that world, when such a huge percentage of the people who need access to treatment because they already are infected with HIV, that using HIV treatment is going to be an adequate prevention tool for all of the people who need it. It would be an unrealistic kind of expectation. I think that the third set of biomedical technologies that it's important to mention, obviously, are the old technologies that were brought in, much like behavioral theories in relation to smoking cessation. Other kinds of approaches, like the male condom, like now medical male circumcision, have been talked about as part of this architecture of biomedical prevention. And once again, extremely important, but also with their limitations. And I won't go into a harangue about the limitations of medical male circumcision, but we could spend at least as much time as I have available for this talk discussing those problems and barriers. Ultimately, we've recognized, like every passing fad in HIV research, we've recognized that biomedical prevention also has its own limitations. One of the consequences of that recognition was to start thinking about what's called combination prevention, and brings in the behavioral and the structural as well as the biomedical, and sort of tries to make everybody happy. But also, while I tend to agree that some kind of combination is ultimately extremely necessary, it concerns me that much of the discussion about combination prevention leaves out a number of things. It's important to ask ourselves what's missing in combination prevention. And I've just made a list here of a few of the things that I think are missing. They almost all come from the complicated middle ground between individual behavior and structure, where even the biomedical must be negotiated in terms of social practices, things like social interaction, things like social networks, things like communities and community support structures, things like community and social mobilization strategies, and things like the big elephant in the room, politics, policies, and programs, and those large-scale political barriers that are out there are not mentioned when we discuss combination prevention. So it's important to remember that the one successful, truly successful response to the epidemic that emerged in the first decade, those community mobilization strategies that changed the behavior of affected communities in places like San Francisco before a single dollar of public money had been spent on responding to the epidemic, they're left out of combination prevention. That's a strange omission, and it seems to me needs to be thought about critically in a particularly important way. I'm rushing to try to finish off before we're out of time for questions, so let me just briefly try to go through some of these last issues, which at some level they're the take-home message, so I can't rush through them too quickly, but I also want to have time for people to be able to talk if at all possible. So I want to mention then what I think is the importance of biopolitics. The social scientists in the room will probably know what I'm talking about when I say biopolitics. The other HIV researchers may well not know because it's a category that comes out of a particular tradition of social theory and social science research associated with Michel Foucault and his followers who look at the implications of the relationship between power and knowledge in multiple dimensions. I think it's important for us to emphasize that one of the reasons why social science continues to be as important or more important now than it ever was precisely because HIV prevention and research are socially produced, they're socially constructed, they're social practices. The way in which we organize the research enterprise is socially constructed. The ways in which we disseminate research findings is socially constructed. The ways in which we translate from research into practice and in programs is socially organized and so on. Knowledge production, AIDS policy debates, public health programs, their design as well as their implementation, and community-based responses to the epidemic are all socially produced. They're socially produced at every level and on multiple dimensions, and it is only through social science investigation that we're able to understand that more fully. And because of that, I think that social science will have to continue to be not just a handmaiden of other forms of HIV research, but a fundamental partner with other kinds of research to be able to respond to the epidemic, even in an era of biomedical prevention that we hope will prove to be more effective than other approaches, but that the jury is still out on that. Some of the reasons, I think, some of the reasons, okay, we seem to have lost a slide. Okay, so I don't have the slide, but let me just say some of the reasons that I think that social science matters now more than ever. One is the central role of reflexivity in the epistemology of the social sciences. The social sciences are basically the only science that thinks reflexively about what it is that it's doing, and that therefore has a toolkit that enables other aspects of science, including biomedical research, to be reflexive about what's going on in the construction of biomedical research, to understand the paradigm shifts that happen when we realize that combining antiretroviral therapies will actually be more effective. And how does that lead even the biomedical scientific enterprise to change in profound ways over time? Because biomedical prevention is socially constructed, understanding and interpreting and figuring out how to roll out effective biomedical prevention techniques, even when we have them, can't be done without social science. We know after nearly 20 years of trying to roll out antiretroviral treatments that it isn't easy. And we're going to have to face with vaccines or with microbicides or with any new biomedical technology that we have, there are profound kinds of barriers. Just see how people react when you try to circumcise them in Lesotho or some places in the world where circumcision is not an obvious kind of response to people's cultural realities. So because of the socially constructed nature of biomedical prevention, it requires social investigation and social analysis in a profound way. And then the importance of analyzing the social organization of health services and what might be described as the political economy of service delivery. I've already alluded to this. You don't just roll it out. It isn't that simple. There are all sorts of political, economic, social, cultural barriers that need to be confronted, and to confront them, you need to understand them. And social science does allow that to happen in important ways. Social science also allows us to confront some of what I think we might call the necessary fictions that exist in relation to the epidemic. By necessary fictions, what I mean here, and it's not I didn't coin the term, I got it from John Gagnon, and he probably got it from somebody else. But what it means is that over the course of the epidemic, those of us who've been engaged in trying to respond to it have spent a lot of our time creating necessary fictions. That is to say, creating ideas about the epidemic that we knew were probably not correct, but that we needed to be able to confront it in an effective way. There was a time in the 1980s when no one at an official level was responding to HIV because of stigma and discrimination that they had in relation to the populations that seemed to be most affected, when we created the necessary fiction that AIDS is a democratic epidemic, that everybody is equally at risk, and because everybody is at risk, because the general population therefore is at risk, we needed to have a different kind of political response. We knew at the time that it wasn't that simple, that maybe everybody is at risk in some societies, but that there are lots of things that make risk differential for different people. But we needed to create the fiction of the general risk of HIV to be able to try to move the Ronald Reagans of the world in the right direction. In the 1990s, we created all sorts of necessary fictions about the numbers. Elizabeth Pisani, in her book, The Wisdom of Horrors, calls it beating up the numbers. And we did that at WHO, and we did that at UNAIDS, and we made projections and created models that were larger than in fact the epidemic became, and at some level most of the people involved in creating those, and I have my share in it, probably knew that they were overblown. But we considered them a necessary fiction to achieve the strategic aims that we wanted to achieve in terms of policy and politics. The necessary fictions that seem to dominate the landscape at this point in time, Richard Elliott also spoke about this last night, the idea of getting to zero, which is UNAIDS speak, the idea of working towards an AIDS-free generation, which is PEPFAR speak. That's what you'll get from Hillary Clinton. Obama on the slide last night was talking about maybe starting the end of AIDS. He wasn't going all the way, but if you look at some of the use of the end of AIDS language in the popular press and even in scientific journals such as The Lancet, but especially in popular venues such as Huffington Post or other kinds of blog speak sorts of places, this idea that we're close to curing AIDS, that a cure is possible, that the epidemic is about to end, is a strange contemporary necessary fiction that I think we have to look at with a great deal of concern. I do think, having been part of necessary fictions for a long time, that there are strategic uses for the cure of AIDS. Back in the 1990s, Herbert Desai edited a book of writings by an AIDS activist in Brazil called The Cure of AIDS. And we posited, because he posited, that you have to imagine the possibility of a cure to be able to continue to engage people in the struggle. And I think that's a meaningful and logical reason to talk about the cure. But I don't want us to sort of fall into thinking that we're perhaps closer to the cure than we in fact are. And yes, it may be that tomorrow another baby who has been cured is announced in the popular media, and that will add into the notion of cure in important ways. but we need to recognize, again, going back to the fact that we haven't been able to roll out anti-retroviral treatment to more than a third of the people who need it, that going from a cure, even if we had it, to actually putting it into place has huge political barriers that are going to need to be confronted. And again, social science and social research gives us some tools for doing that. Among other things, it tells us something about why narratives matter. Narratives have been profoundly important, as important, I would argue, as epidemiological data from the very beginning of the epidemic. Narratives are important because they give the epidemic a human face. Narratives are important because responding to and understanding the epidemic requires us to understand that it isn't only about numbers, it's about names. That was the power of the Names Project. It put names and pictures and faces and lives on the reality of those epidemiological numbers. It made it real for us at a human level. It humanized the epidemic in profound kinds of ways. And narratives are important ultimately because we respond to the epidemic as social persons, as members of communities, and ultimately all of us respond to it as political actors. And the narratives that we have, the social and cultural imaginaries that we use, help us to, we tell stories about the past and we tell stories about the future. We tell stories about the communities that we're part of. We tell stories about the political struggles that we engage in. Narrative is important for all of those reasons. They're important because they give us meaning and help us to figure out why we're doing what it is that we do and why we go on doing it. And again, narratives are things that social analysis and social science help us to understand, help us to work with, and help us to build a multi-dimensional response to the epidemic, making human the numbers, making human the biomedical data that we have, and helping us to understand why it is that we do what we do. So the end point in my argument is that social science is in fact as important now as it's ever has been. It will continue to be important precisely because of the complexity of the lived human experience of the epidemic, and it provides us with a toolkit to try to address that complexity. I'm going to stop now. There's the slide. It somehow got out of order. There's a thank you slide, so thank you very much.
Thank you very much, Richard. And we waited too long to see you again. And I'm one of the persons who was there in 1997, barely alive because they had just given us the drugs a year before. And I'm very happy to be here to thank you for your remarks. We won't have time for a Q&A now, but you must feel compelled, as we do, to have a conversation with Dr. Parker, with each other about why these narratives matter, why we're immersed in them as much as we are in numbers. And so we thank you so much for your attention and so much to you for being here. And this is a token of our appreciation.
Thank you very much.
Thank you. I think we're reminded now, and thanks again to Jackie and Zach. I think we made the perfect choice. Thank you. So I think you need to go and have a coffee break and catch your speakers and networks. Thank you very much.